Yeah, thank you. Good afternoon, everybody. I'm here to present this case, which one I faced in my consultation. I have no conflict of interest, and the case is about a 70-year-old man, former smoker, that has a history of occupational asbestos exposure for 35 years. He was a builder of the industry of shipbuilding. And as relevant previous medical history, he suffers from arterial hypertension, benign asbestos-induced pleural disease, and it was submitted to a thoracoplasty of the 6th to the 10th ribs in 2015 due to a pleural emphysema with pleural cutaneous fistula. That surgery resulted in a chest wall deformation, in a restrictive ventilatory defect, and a chronic hypoxemic respiratory failure. As we see here in the post-surgery X-ray, we see the chest wall deformation on the left side with missing ribs. The patient was living his normal life, normal activity life, till the 18th of August of 2018, when he started to feel acute onset of acute prostration and acute onset of dyspnea at rest. And then he was transferred to the hospital. At hospital admission, he was received in a respiratory arrest under bag mask ventilation, and physical examination revealed a Glasgow Coma scale of 3. The patient was hypotensive with a normal heart rate, and there was an absence of lung cells in the lower third of the left hemithorax that he was supposed to, according to the surgery. Initial evaluation revealed a respiratory acidosis with a pH of 695 and unmeasurable PCO2 and bicarbonates, and blood tests revealed a mild leukocytosis with neutrophilia and acute kidney injury, hepatitis, and increased CRP with 13 with normal procalcitonin. I don't know if you can see, but the X-ray at admission revealed a diffuse accentuation of the lung parenchyma. We couldn't see exactly if there's any signs of consolidation in the X-ray. Initial electrocardiogram and echocardiogram were negative for the presence of myocardial infarction, and even CT, cranial CT scan, was also negative for the presence of stroke. So we performed the thoracic CT, and we saw that there were no signs of pulmonary embolism and no signs of consolidation suggesting the presence of pneumonia. But we see that the patient has thickening pleural at the left side and with right pleural effusion, and as a consequence of the thoracoplasty, he has a missing ribs and he has a defect of reduction of lung volume on the left side. The patient was intubated and was transferred to the intensive care unit, and the invasive mechanical ventilation was initiated, initially with pressure control ventilation with a pressure support of 25 and then expiratory pressure of 5. That resulted in tidal volumes around 360 millimeters. The patient started to get better, and on the 4th day of ICU stay, the patient was ventilated under pressure-assisted ventilation with a pressure support of 21 and ending expiratory pressure of 5. Arterial blood gas evaluation at that time revealed mild sustained hypercapnia. But since the patient was better and was not under any sedatives or under cardiac and vasopressor support, the patient started to be weaned with reduction of the pressure support, and then was weaned to spontaneous ventilation under oxygen therapy supplementation. Although due to increase in hypercapnia and increased respiratory effort, we have to move the patients and connect them to continuous non-invasive ventilation, mechanical ventilation, in order to try to avoid a reintubation. And he was connected to bilevel spontaneous temporized mode with an inspiratory pressure of 20 and expiratory pressure of 5. The patient was not reintubated. He was getting better, the respiratory effort decreased, and he was comfortable under non-invasive ventilation. And on the 20th day of hospital presence, he was discharged from the hospital, connected with nocturnal non-invasive mechanical ventilation with a bilevel spontaneous temporized mode, having an inspiratory pressure of 16 and expiratory pressure of 4. And at that time, arterial blood gas evaluation revealed a normal pH and with increased hypercapnia. The patient was discharged, and almost 9 months after, he was present in the pulmonology appointment maintain nocturnal non-invasive mechanical ventilation with good tolerance, and arterial blood gas evaluation at that time was slightly better with a chronic hypercapnic hypoxemic respiratory failure. At that time, reevaluation of the patient, he had no new episodes of respiratory infection or acute on chronic respiratory failure since hospital discharge. He complained on dyspnea on exertion grade 3. Lung function tests revealed slight severe restrictive defect, and the reevaluation echocardiogram revealed new signs of suspicion of pulmonary hypertension. Unfortunately, on the following follow-ups consultation, the patient got worse and got more dependent on nocturnal and now diurnal non-invasive ventilation, and he had to start long-term oxygen therapy. So in resuming, we had a patient that was hospital admitted with acute respiratory failure with hypercapnic coma due to non-treated severe restrictive ventilatory defect. No precipitating factors were identified in hospital investigation. He was admitted to the ICU, and due to persistent hypercapic and respiratory failure, the patient was weaned from invasive mechanical ventilation to non-invasive mechanical ventilation. And after discharge, he was treated and continued treated with long-term non-invasive ventilation and long-term oxygen therapy. So in conclusion, we don't see that much thoracoplasty nowadays, but it is a surgery that as a consequence will lead to dyspnea, severe restrictive dysfunction, and chronic hypercapnic respiratory failure. It was shown before that patients with thoracoplasty might experience an abrupt clinical deterioration with severe hypoxemia and hypercapnia, and most of the times no precipitating factor is identified. So it is important to keep this patient under regular follow-up in order to monitor the development of respiratory failure and anticipate the need for treatment with oxygen and non-invasive mechanical ventilation. Thank you.
Thank you very much. Any questions from the floor?
A little comment. I would suggest for you to do the night study on this guy, because if you look at the bases, they were rather high compared to the PCO2. So there is a likelihood that he has nighttime hyperventilation on top of the restrictive problem in the lungs. So probably if you increase the EPAP or PEEP, it would be more efficiently ventilated.
Yeah, we keep him under regular follow-up. He has performed one. He has a nocturnal hyperventilation, and we are trying to titrate the pressures in order to correct it, although it is not possible to correct it to normal levels. We have achieved the best that we can according to his tolerance and according to what we think he can perform.
I will try it higher.
How higher we have the IPAP? Now we have
6, but this is low.
EPAP.
EPAP.
Yeah, we have 6.
For the PEEP, we would leave in such a case probably something between 8 and 10, or titrate it on the polysonography and a capnography. During an AV.
Okay.
How long is the patient now since he was in hospital?
Now it's 5 years past.
Okay, very good. And he's still going?
He's still going.
That's the main thing. All the rest is irrelevant.
Yeah.